Hello, everybody. Welcome to this new Frailty seminar. My name is Dr. Carmen Castillo-Gallego. I am a geriatrician and researcher in Hospital Virgen del Valle in Toledo, Spain. And I am a member of the organizing committee of this Frailty seminar series. And today it is my pleasure to introduce Dr. Mikel Izquierdo, who is going to talk about ViviFrail exercise for older adults with frailty. But before doing so, I would like to remind you a couple of things. In April 20 till April 22, the ICFSR meeting is going to take place in Boston, and there is a late call for abstracts till March 17, in case anybody is interested. And I would also like to remind you that after this talk, we have a few minutes for questions and answers. So if you have any question, please write it down in the Q&A section that you have on the screen below. And with no further delay, I will introduce Dr. Mikel Izquierdo, who is head and full professor of biomechanics and exercise physiology in the Department of Health Sciences of the Public University of Navarra. He also holds an appointment as a professor of sport biomechanics at the Center of Studies of the Spanish Olympic Committee. And from 2005 till 2010, he was the head of the unit of the Research Studies and Sport Medicine Center of the Government of Navarra. He is principal investigator and collaborator in several European Union funded projects focused on frailty and exercise, such as ViviFrail and ViviFrail. He is involved in an Age 2020 funded project of the European Commission called ViviFrail Latam, and is collaborating with the World Health Organization in the implementation of a physical exercise program as a global strategy of intervention in frailty and risk of falling prevention. Professor Mikel Izquierdo has published more than 380 original articles in peer-reviewed journals and has supervised more than 30 PhD students. So thank you so much for collaborating with us, and you can start whenever you want, Dr. Izquierdo.
So we start again, sorry, yes. So as I told you before, I am very proud of participating in this series of seminars. My name is Mikel Izquierdo. I am professor of physiotherapy and exercise science in the Public University of Navarra in Pamplona. And for the next few minutes, I am going to entertain by give you a quick look on the importance of maintaining exercise during in hospital, nursing homes, or stay-at-home periods. And in addition, I would like also to give you a quick look on the recent international expert consensus guidelines of exercise recommendation in older adults. And finally, I will focus on ViviFrail multi-component exercise program. I have nothing to discuss. Societies are, you probably well know, are progressively aging, and people aging more than 85 years who are projected to more than triple in number by 2050 represent the most rapidly expanding population group. How to preserve health and function at advanced age is an increasingly important challenge for healthcare professionals and the public in general. We will afford these topics in the following slides. This figure illustrates the 9 candidate hallmarks of aging by Lopetegui. Primary hallmarks, colored in blue, are negative processes that progressively hasten aging. Antagonist hallmarks, you can see in red, are necessary processes that can become negative if present in excess. And integrative hallmarks, colored in yellow, are those that directly affect tissue homeostasis and function. This overall aging hallmark result in several chronic changes at the multi-system physiological and that eventually result in loss of muscle mass and functional decline. The human aging process, you know, is universal, ubiquitous, inevitable, and decremental. Every physiological function is being continually diminished. At around 20-30 years of age, humans have acquired all the physiological development that they will attain. From that stage, the aging process commences, although the rate of change is heterogeneous. This process will continue up to 6 or 7 decades, ending in death. In this figure that we published in a recent consensus, international consensus on exercise and physical activity, we suggest that there is a range between two distinct phenotypes of aging, shaped by patterns of living, experience, and behaviors, and in particular by the presence or absence of helpful levels of physical activity and exercise. As you can see in the figure, in the presence of physical activity, lifestyle-related disease such as cardiometabolic disease, obesity, and cerebrovascular disease, for example, are prevented or ameliorated. Exercise may be used here as a preventive measure in conjunction with other lifestyle factors such as diet. At one end of the physical and exercise continuum lie lifelong exercisers and competitive master athletes. Towards the end of the spectrum, and in the absence of adequate physical activity or exercise, the aging process is associated with the premature and excessive appearance of disease and dysfunction. These diseases contributing substantially to all-cause mortality and include cardiovascular disease, type 2 diabetes, obesity, diminished muscular function, mental health problems, and increased end-of-life morbidity. Physical activity here operates as preventive medicine in the minimal disease phenotype, while in the lifestyle-related disease phenotype, physical activity tends to be applied for downstream from the initiation of pathological processes and therefore operates as a true therapeutic agent, where it follows the precept of identifying the cause of a disease and then using an agent to eliminate or moderate the disease. As we mentioned in this consensus, however, a choice is available for many of them. The choice will have a great influence on aging trajectories. There are many factors that make up a lifestyle, but in the context of this article, it is the effect of physical activity, the effect of exercise that is of particular interest, as it optimizes physiology when engaged with adequate doses and modalities. Both, you can see in the figure, structured exercise and overall physical activity play important roles as preventive strategies for many chronic diseases, including cardiovascular disease, stroke, diabetes, osteoporosis, and obesity, improvement of mobility, mental health, and quality of life, and reduction in mortality, among other benefits. Notably, exercise intervention programs improve the hallmarks of frailty and cognition, optimizing functional capacity during aging. In this pathological condition, exercise is used here as a therapeutic agent and follow the precepts of identifying the cause of a disease and then using an agent in an evidence-based dose to eliminate or moderate the disease. In the figure, we can see the relationship between risk of functional, physiological decline during aging and the level of physical activity. How we should preserve functional reserve across multiple systems to combat frailty and disability at advanced age is a major challenge for modern medicine, which at least up until now cannot be resolved using drugs or drugs combinations. In this respect, exercise here appears as a potential solution. For example, skeletal muscle has been described as endocrine organ that can produce and release myokines into the bloodstream, particularly during muscle contraction, where they function locally or systemically to elicit a myriad beneficial effects, including decreased inflammation and insulin resistance. The anti-inflammatory milieu created by exercise training is believed to be mediated legally by myokines, which protect arteries against the progression of arteriosclerosis and stenosis and preserve the stable phenotype of pre-existing arteriosclerosis plaques. In regard with resistance training, the good news is that tremendous therapeutic potential, particularly in patients aging more than 60 years with cardiovascular disease, as it can counteract, you can see in this figure, the loss of skeletal muscle strength or muscle mass, while improving glycemic control and decreasing visceral fat. Increases in muscle strength resulting from resistance training may also prevent cardiovascular disease itself. Exercise also and early rehabilitation protocols applied during acute hospitalization can prevent functional and cognitive decline in older patients and are associated with a reduced length of stay and lower cost. Yet, patients with cognitive impairment or multimorbidity at baseline are commonly excluded from exercise intervention trials, and only conservative or traditional programs, for example, focusing on light walking while avoiding resistance training, have been typically applied to elders who are acutely hospitalized. The benefits of a multi-component exercise intervention consisting of resistance, power, balance, and weight returning exercise are good solutions to attenuate functional decline in frail nonagenarians in long-term care, as we can see in recent results. For instance, meta-analytic evidence support the benefits of exercise interventions on the functional status of medically stable patients, for example, in the post-acute or rehabilitation settings, and on other clinical outcomes such as risk of nursing home admission and mortality. There is also evidence of a benefit of exercise intervention on functional independence and physical performance in older adults admitted for an acute medical condition. In a couple of recent studies published in JAMA Internal Medicine, our research group explored the possibilities of modifying traditional model of hospitalization in acute care of elderly units, but goes a step further by adding the individualized and adapted prescription of multi-component exercise to each patient. Other studies shows that an individualized multi-component exercise intervention, including low-intensity resistance training, performed during a short period, 5 days, provides a significant benefit over usual care and can help to reverse the functional decline associated with acute hospitalization in other adults. Acute hospitalization, as you know, per se led to impairments in patient functional ability during activity of daily living, whereas the exercise intervention reversed this trend. These findings open the possibility for a shift from the traditional disease-focused approach in hospital acute care units for elders to one that recognizes functional status as a clinical vital sign that can be impaired by traditional bed-rest hospitalization, but also effectively reversed with specific in-hospital exercise. As earlier mentioned, acute illness requiring hospitalization frequently is a sentinel event leading to long-term disability in older people. Prolonged bed rest increases the risk of developing cognitive impairment and dementia in acutely hospitalized older adults. Exercise protocols applied during acute hospitalization can prevent functional decline in older patients, but exercise benefits on specific cognitive domains have not been previously investigated. Our research group had the purpose to assess the effects of a multi-component exercise intervention for cognitive function in older adults during acute hospitalization. We therefore show that an individualized multi-component exercise training program may be an effective therapy for improving also cognitive function, for example, executive function and verbal fluency domains in very old patients during acute hospitalization. COPD or diabetes is expected also to affect approximately half of the elderly population in the next decade. The incidence of hospitalization associated with this condition is also likely to increase, even surpassing caused by major conditions, particularly ischemic cardiomyopathy. In this context, the collateral effect of hospitalization, even for a few days, should not be overlooked, especially in the older segment, people aged more than 80 years. Our findings in recent study also add to the existing limited literature and support the benefits and safety of early rehabilitation programs in acute hospitalized older patients with COPD or diabetes type 2. Of note, the fact that our results were found in very old people with more than 87 years on average, extend the potential safety of this type of interventions. Recently, our research groups proposed that metabolome analysis will have also a suitable niche in personalized medicine for physically frail older adults. In the person-targeted lipidomic approach, we found that 5 circulating metabolites, including ceramides, cholesterol, and phosphatidylcholines, were significantly increased in physically frail compared with robust older at hospital admission, pointing to the existence of a lipidomic profile of older adults with physical frailty. The non-targeted metabolochem study can open a wide view of the physically frail features changes at the plasma level, which will be linked to the physically frail phenotype at hospital admission. Also, we propose that metabolome analysis will have a suitable niche in personalized medicine for physically frail older adults. Well, recent systematic reviews and meta-analyses have concluded that physical exercise is beneficial to reduce the risk of several conditions associated with an advanced age, such as frailty, cognitive decline, low muscle power, or poor functional capacity. There is also an evidence that exercise intervention programs can prevent falls in older people with minor concomitant adverse effects. This systematic review concludes that long-term exercise does not influence the risk of dropouts due to health issues or mortality in older adults, and results in a reduced mortality risk in clinical populations. Exercise reduces the number of falls and fall-associated injuries, and improves physical function and cognition in this population. Long-term exercise training interventions are an effective and beneficial strategy in older adults for the prevention of fall-associated injuries and improvement of physical function and cognition. Well, in a recent international exercise consensus that you can make a free download from the special issue of the Journal Nutrition Health Aging, we provide an evidence-based rationale of using exercise and physical activity for health promotion and disease prevention and treatment in older adults. Exercise prescription is here discussed in terms of the specific modalities and doses that have been studied in randomized controlled trials for their effectiveness in attenuating physiological rates of aging, disease prevention, or improvement of older adults with chronic disease and disability. Recommendations are also proposed to bridge gaps in the current literature and to optimize the use of exercise or physical activity or both as a preventive medicine and as a therapeutic agent. Thus, as we mentioned, the actual utility of exercise as medicine is fourfold. First, to exploit its potential to prevent diseases for which we have available treatments. Second, to serve as an adjunct to effective medical or surgical intervention where they do exist. Third, to substitute for harsh treatments for which exercise represents a better and safer alternative. And fourth, to become mainstream in the management of conditions for which there is no other effective treatment. The latter category represents the most pervasive and morbid conditions of older adults globally: sarcopenia, frailty, disability, and dementia. We also summarize, as you can see in the slide, data from both epidemiological studies and experimental trials to support the training of all physicians, including geriatricians, in the basics of exercise prescription for health-related quality of life, maintenance of functional capacity, as well as design studies supporting the benefit of physical activity for bone health, increase of muscle mass and strength power, and reduction of adipose tissue. The ViviFrail multi-component physical exercise program to prevent frailty and the risk of falls represent an excellent example of an evidence-based program. This whole project is based on the idea that health in other people should be measured in terms of its function and not as a disease that determines life expectancy, quality of life, and resources of support that need each population. The general objective is to maintain a level of functionality that maintains the highest degree of autonomy possible in each case. ViviFrail helps you to design a program for all people above 70 to promote the practice of physical exercise to improve strength, gait ability, and balance while frailty and falls are also prevented. For this, we propose to enhance the promotion and prescription of a multi-component exercise program, creating synergies among the field of sport and the health and social care services. This programmed intervention prescribed shall include resistance, balance, endurance, and coordinating training, besides multi-component exercise that include resistance, as this specific type stimulates several components of physical health and appear to be the most effective for improving overall physical outcomes among frail people, as well as for preventing disability and other adverse illness. We develop a specific passport or guide of physical exercise for professionals and specialists in physical exercise. It includes all the necessary steps for the implementation of the ViviFrail program. This guide offers a series of exercises that will, depending on the elderly person functional capacity level, serious limitation, moderate limitation, and slight limitation, as evaluated by the SPPB and a walking test, work on arm and leg strength and power, balance and walking to prevent falls, flexibility, resistance with cardiovascular exercises. All the exercises outline the procedure, the guidelines for starting, frequency, and progression to be able to correctly monitor the instructions prescribed to the patient and improve their health. We should begin with the aim of choosing the type of physical exercise program that is the best for each person, doing an assessment of the functional capacity, as you can see in the poster, using the short physical battery test. This battery test should be performed prior to the beginning in order to determine the functional capacity and most adequate exercise program that are most likely to bring about any improvements and be able to make progresses. Depending on the result attaining and if the person makes progresses, work shall begin on the next level. On the other hand, and due to its immense clinical relevance, as indicator of weakness in frail people, doing a 6-meter walking speed test and a get up and go test is also recommended. This type of test also helps to determine the initial level and monitor the benefits of a physical exercise program. Finally, 4 simple steps are suggested to determine the risk of falling and be able to prescribe a specific fall prevention program for the elderly. The efficacy of these programs will improve if the physical exercise is accompanied also by an assessment of the patient's nutritional status and the corresponding nutritional intervention. The risk of falling is one of the main consequences of weakness and is the cause of 90% of all hip fractures. This event is also fundamental in patients with cognitive deterioration. Doing the following assessment is suggested to be able to detect a high risk of falling and be able to prescribe a specific training program for this type of person. A high risk of one or more of the following: 2 or more falls in the last year, 1 fall in the last year requiring medical attention, time get up and go more than 20 seconds, and a speed velocity less than 0.8 meters per second. As I mentioned before, different functional capacity levels have been determined based on the scores obtained from the short physical battery test and the 6-meter walking speed. You can see the graph, the figure, which is one leading to the recommendation of a certain customized multi-component physical exercise program, program A, B, C, or D. The efficacy of this program will improve if the physical exercise is accompanied, as I mentioned before, by an assessment of the patient's nutritional status and the corresponding nutritional intervention. ViviFrail has individual prescription passports for older adults, which can be implemented during unsupervised sessions. The exercise recommendations are tailored to the older personal functional capacity level, several limitation, moderate, and slight limitation, and the risk of falling. As you will see, there is a suitable passport for each elderly person according to the level of functionality. And in addition, the passport with the plus symbols are those for people at risk of falls. You can see an example of a passport for a person with a slight limitation, a person with type C. And more recently, in this video, you can see a collaboration with the PAHO and the Government of Navarra. You can see in Spanish, sorry, some examples of how we can manage the program.
Hola, soy Mikel Izquierdo, catedrático de la Universidad Pública de Navarra, investigador del Navarra Biomed y director científico del programa ViviFrail.
Hola, soy Nicolás Martínez Velilla, jefe de servicio de geriatría del Complejo Hospitalario de Navarra e investigador de Navarra Biomed.
Para evitar caídas, también tenemos que utilizar ropa y calzado cómodos.
Vamos a buscar una carga o una botella de agua, una carga parecida con la de las botellas.
Pero lo más importante de todo, hay que disfrutar de la actividad. En los
Para utilizar en
ejercicios,
este programa es una toalla, 2 botellas de agua y un globo. ¡Ánimo con ello!
As I comment, in addition to the passport and to the different materials, and in collaboration with the PAHO, we published demonstrative videos of physical exercise program for all people with different functional levels that have been published and that can be free download in our page ViviFrail.com. The intention also of these videos is to provide all the people with examples of different multi-component physical exercise program based on the ViviFrail methodology. Well, you can see also some tips for monitoring, for seeing some symptoms of intolerant to physical exercise while doing exercise. A few tips and recommendations to perform every type of mode of exercise. Some tips, for example, for make strength and power exercise. And we also develop specific wheels for each functional level that include the exercise, series, and repetitions that should be done every week. You can make, as I mentioned, a free. You can make a free download of the resources, videos of the exercise, and extended information about ViviFrail in several languages. We already have translated the program into Spanish, of course, but also into English, French, Portuguese, Chinese, Polish, German, Italian. So you have no option to non-bake ViviFrail. Also, you can install the ViviFrail app that will allow you to digitally track the exercise program. Finally, I would like to show you some evidence-based results in connection with ViviFrail. In this regard, it has been recently reported that ViviFrail multi-component tailored exercise program in nursing home residents was very effective in the short terms, 4 weeks, and produces a similar response to a training in 2 groups of sarcopenic, frail and institutional adults aged more than 70 years from 2 different nursing homes. Intermittent strategies such as 4 weeks of supervised exercise 3 times yearly with no more than 4 weeks of inactivity between exercise periods appears an effective solution to the global challenge of maintaining functional capacity and can even reverse frailty in vulnerable institutionalized older adults. Also, we have published recently the protective effect of physical exercise in community-dwelling older peoples and has been well confirmed in the literature, supporting the exercise as a cornerstone for preserving functional status and muscle function in this population. As another good example of effectiveness of ViviFrail multi-component exercise training program is this findings of our recent study, showing that ViviFrail appears to be an effective and safe intervention for improving functional capacity in community during frail, pre-frail, or adults with mild cognitive impairment or mild dementia. In fact, as we saw in the results, a 1 month of exercise intervention is sufficient to enhance physical function in this population. In addition to functional gains, the individualized multi-component exercise program also seems to have a beneficial effect on cognition, muscle function, and mood status after 3 months of exercise intervention. As I mentioned before, also an individualized multi-component SSI program is effective to reverse the functional and cognitive decline that frequently occurs during acute care hospitalization in all the patients. The aim of this study was to determine whether improvements in cognition mediate improvements in physical function in acutely hospitalized other patients. We saw that cognitive function enhancements mediate physically function improvements in acutely hospitalized other adults after an individual multi-component ViviFrail exercise training program. An individualized multi-component exercise program, also with a special emphasis on muscle power training, proved in our recent studies to be an effective therapy for improving muscle power output of lower limbs up to maximal loads and maximal muscle strength in other paddles during acute hospitalization. Well, I would like to conclude with several slides. First, telling that physical inactivity is a key factor contributing to the onset of muscle mass and function decline, which in turn appears to be a recent aspect related to frailty. In view of this, a focus on improvements in function and quality of life may be more beneficial in frail of the patient than other targets for intervention. Also, poor health, disability, and dependency are not inevitable consequences of aging. The promotion of a healthy lifestyle, the avoidance of sedentarism, and physical exercise have proven to be effective for frail other adults, enhance their independence, and probably incur fewer health-related costs. The main interventions that you should know that have proven effective to prevent and even reverse the frail state are physical exercise, multidimensional geriatric assessment, and intervention on major geriatric syndromes, with emphasis on proper adjustment of medications. Intervention to promote physical activity in the population have been effective in improving mobility and function. Other interventions, such as nutritional or pharmacological, are inconclusive. Also, I would like to conclude with these thoughts. Despite its multiple benefits, exercise is not fully integrated into geriatric medicine practice. It is still absent from the core training of most geriatricians and other healthcare professionals. In addition, few studies have explored the potential role of tailored physical activity guidelines to maximize exercise-related effects on function, ability to perform activities of daily living, or on other domains of intrinsic capacity, such as cognitive, physiological, or sensory deficits, for example, vision or hearing, and locomotion or vitality in other adults, which is likely to be related to the paucity of research in the area. Also remark that in an area of complex regenerative medicine, when some scientists are even considering the expansion of human life well beyond its known limits, we must not forget the simple and important messages. Exercise is not just for children and young adults. People of advanced age can adapt to exercise and deserve to benefit from it. Generalists should advise all patients, regardless of age, to be as active as possible. Medical schools should teach students that skeletal muscle remains a plastic, adaptable tissue through the human lifespan. It is never too late and you are never too old to contract muscle. More research is needed on exercise intervention and exercise mimicking treatments such as electrical stimulation for other adults, for example. Further considerations include the cost implication of additional qualified fitness specialists who are essential for the safe supervision of all exercise interventions in other adults. Finally, I would like to thank and to present to the big team I am honored to work with, including associate professors, researchers, clinicians, and PhD students. They make a very good job. Here you have my links, my email, the link of ViviFrail, where you can make a free download of all the materials. Thank you for your attention.
Thank you so much. I think you can see me now, right? Thank you so much for your presentation, Mikel. We have a few questions. One from Saori Arada. I am very impressed by exercise intervention for very elderly patients during acute hospitalization. Who is actually in charge of exercise program at the hospital? Physical therapists, rehabilitation doctors? How many do you have in your hospital?
Well, it's a very good question. I have to say two things. The main responsibility of the patients are, at least here in Spain, the geriatrician. The geriatrician is the cornerstone of all the treatment of the patient. So the geriatrician is the responsible professional to prescribe exercise. So this is the first step. The geriatrician gives the drugs and give the exercise. And after that, who is in charge to execute the program? I think that is your question, more focused on that. To execute the program actually in Spain should be done by the physiotherapists. I say should be done because they are the only professional people who can give exercise in the hospital. But as probably in your country, there are a limited number of physiotherapists in the hospital and other experts, for example, experts in sports, in rehabilitation, in physical activity, should also be included in these teams. I don't know if I give you a good response to your question.
I think that you do. And what do you think about rehabilitation doctors?
I think that the rehabilitation doctors are out of this actually. I don't know why. They are understanding the potential role of physical activity and exercise for a lot of disease, but actually are out, mentally out, I mean, from this concept. I think so. Sorry for telling you that true. But in the case, I cannot imagine a physical rehabilitation doctor making ViviFrail with a patient. I mean, probably they have to do other things.
Mm-hmm.
I don't know.
They don't like Frailty. Okay, another question. Thank you for a great talk. This will be a wonderful resource for our patients in the Miami VA. Do we need to register anywhere to refer our patients to these resources, or can we simply give them the passport and information for the app? Thank you.
Thank you for the question. It's free. You can make a free download, but be quick because we are going to start to get money with that. No, it's a joke. It's a free program. You can make a free download. Just we ask that you mention the number of the ViviFrail and that's it. Yeah.
Another question from Shabnam Salimi. Wonderful talk, thanks. Past few years, cardiovascular incidents have decreased compared to the last, but functional decline and disability have not decreased. If exercise is a common path for these two health states, how do you explain the paradox of decrease in cardiovascular disease and increase in disability?
Well, maybe we can write an editorial on that. I just mentioned one experience that we have suffering. We have living in the last 2 months. We are in contact with health failure patients and with cardiologists, experts in health failure patients. The cardiologist has known now that they have spent a lot of money in drugs and in tools and in equipment to manage the health. But they already know that the patient said that I am dead but living. So they are focusing on muscle, on function. So even for cardiovascular disease, maybe the problem is not the heart, but maybe the problem is the muscle. So this is probably can explain some different because some different between disability and frailty and some concepts that you mix in your question. I think that it's difficult to give you the question now in English and without think a little bit more. But I will try to give you a response in the future. Maybe it's a good editorial.
Another question from Olga Theo. Great, which is one of the member of the organizing committee. Great presentation, Mikel. Thank you. Do you find that it is problematic that the current physical activity guidelines recommend 150 moderate vigorous physical activity, a goal which most older patients, especially at higher levels of frailty, is very hard to achieve?
Yeah, so a good question. We have to differentiate two things: physical activity guidelines and exercise prescription. Actually, physical activity guidelines are not for all the people. Sorry, they are not for all the people. They are not for all the people. People of the hospital and all the people more than 85 years old with frailty cannot make 150 minutes a week. So this is important to think about that. And thinking on that, we are focusing on exercise program. There are a lot of research in the world that are suggesting different exercise programs. So it's different exercise than physical activity. Physical activity, actually, the physical activity guidelines that WHO published recently is not for this kind of people. It's not for that. And for other people, other people that is not included in with a robust physical phenotype. Okay. Yep.
Okay. I have many questions. Okay, another one. Thank you very much for this important topic. What steps are needed to implement geriatricians in hospital settings to teach hospitalists primary care of the importance of frailty and exercise programs?
Well, I am not a geriatrician, sorry, but I think from my point of view that the first step is to teach physical activity prescription to medical doctors in the universities. It's the first step. So if we are already trying to do that, if we include the physical activity, the exercise prescription in the knowledge, in the curricula of the professional, the future professionals, we have made the first step. And after that, I think that is a professional problem that I don't know, I cannot tell you how to manage that. But from my perspective, first, we have to teach to the university, in the university, and after that, start to work on that, I think so.
Another, how often is it recommended to reassess the patient to whom we teach ViviFrail exercises to see improvement in SPPV?
Every 6 to 8 weeks. So actually in the program, we have a retest session after 8 weeks, and then we recalculate the loads, recalculate the intensities, and probably we give other passport, other level. So every 6 to 8 weeks.
Okay. Another question from Tony Burns. Thank you so much for a really insightful presentation. I am watching from Scotland. My brother and I deliver multi-component exercise programs to elderly care home residents, mostly armchair based. We normally deliver body weight exercises. What is your thoughts in body weight versus resistance in frail residents? We know Professor Morley very well.
I know who you are. And I remember that I can give you a response by email. Sorry, because my fault. Okay. So ViviFrail is for everybody. I mean, we think a program for people who don't have material, don't have equipment, and we try to make simple a very difficult approach to exercise prescription. Okay, so my first suggestion is that if you have material, machines, you can use machines. Probably they are much more better than a TheraBand, an elastic band. Okay, but if you don't have machines, you have other, you can do other options. I mean, you can use body weight, you can use elastic. The more important thing on that is that you calculate the proper intensity of the exercise program. In the ViviFrail, the algorithm can help you to understand which kind of exercise you can use in connection with intensity. So just a quick advice is use, detect, select an exercise, an elastic band, and a bottle of water that you can do about 20 to 30 reps. This represents that this elastic band, this exercise, the body weight exercise, is getting you about 30% of your maximal voluntary contraction. So we have to choose a minimal intensity with enough stimulus to promote adaptation. This is the more important point in the ViviFrail in connection with resistance training.
Okay, another question from Eduardo Lusa Cadore. Mikel, congrats for your presentation. Considering that people graduated in sports sciences have a more complete formation in exercise progression, do you believe that they are paramount in longer interventions after hospital discharge, community dwelling, older, etc.?
Yes, of course. Hi, Eduardo. Sport science, people who is learning sport science, who is learning physical exercise prescription, actually has more knowledge about exercise prescription that some of the professionals that should do this. So I give you my response.
Dina Katsoulis, thank you hello from Toronto, Canada. Great talk. Your recent guidelines for older adults briefly mentions power training. Do you see great potential for power training in frail older adults for improving physical function, especially if pneumatic equipment becomes more common in various settings?
I have to disagree a little bit. We write at least one page on that. Muscle power training, it's one important mode of training that you should include in your routine. Actually, the first studies of muscle power we developed with Professor Keijo Häkkinen in my PhD in Finland 25 years ago. From that point, a lot of research groups around the world have detected that muscle power should be included in the exercise program of this kind of this type of population. So I recommend that you make power training, and we have a lot of literature supporting on that. Yeah, but we write a couple of pages on the consensus.
Well, I have a question for you, Mikel. And do you think every patient in acute hospitalization should be trained, or should receive rehabilitation, or would you do some assessment during hospitalization?
Well, we have more data that I didn't show you, but there is at least less than 15% of the patients who are in an acute hospitalization unit who are not responders to exercise. This group of people also no response to pharmacological agents, and probably they don't have to do exercise. But the other group of people should be included, as we have published it in one randomized control trial and also in a multi-center randomized control trial, because it's very effective, only 3 days of exercise. So I will recommend on that. The point here is that why not?
Why not?
Okay. Why not? And you can tell me, because you are a geriatrician, and you can tell me, Mikel.
I will say everybody.
because we don't have time, we don't have knowledge, we don't want, a lot of things around. But actually, the evidence is on the desk. It's already published.
Everybody should exercise for sure. Another question from Maria Teresa. Hello, Mikel from Igualada, Barcelona. Congratulations. We used ViviFrail in the fracture liaison service. and we are very proud of that. But I would like to know some advices to improve adherence on it. Hacks. I am a physiotherapist sorry.
Well, you make a good question. Actually, the good question is that how we can improve adherence to the physical programs. It's our job to discover on that. The problem is that we don't know a lot of things about the exercise, motivation, emotions, engagement. So actually, I recognize that we have made just a small piece of the cake. So we need to know this question that you asked me, how we can engage and improve the adherence to the program. It's a good question and a difficult question to give you the response. Sorry. There are some tips that you can use. It you can read in the consensus, but actually I have to recognize that we don't know.
And Kabir Sadara, hi Mikel, excellent presentation. I have a question regarding implementation of technology in older adults. What have been the barrier for adherence of exercise programs? I think he's asking why we don't have an app to follow elderly at home, like a cell phone app or something like that, to have some kind of follow-up in the distance. I guess that's what he's asking.
It's the same question that I tried to mention
Exactly.
before. Actually, in the hospital, in the geriatric unit, my colleague, Professor Nicolás Martínez Velilla, is involved in some projects with virtual reality, with gamification, with technology, with telemedicine, with exercise videos, iPhones that can help to the group of people. But it's a challenge that we have to explore in the future. Yeah.
Okay. So another question. Let me see. How is resistance training compared to aerobic training decreasing new cases of dementia, if there is a difference?
Well, further study has to be done. I cannot give you I am not going to tell you that resistance training is the best solution in the world, but has some challenge to be compared with aerobic training. Probably I will suggest with the evidence that resistance training are more effective with mild cognitive impairment, with mild dementia, than aerobic training. There is a lot of literature coming from that.
Okay, I think we don't have more questions coming. We have a few minutes left. It was a wonderful talk, Mikel. I have to say that I don't prescribe medication, but the thing I prescribe the most is ViviFrail in my outpatient clinic, for sure. And it actually really works. It's an excellent tool, and I thank you for your work. With the minutes that we have left, I would like to remind everybody that in 1 month, on March 9, we have another webinar, which is Lifestyle, Hormonal, and Anabolic Intervention to Ameliorate Frailty by Dr. Dennis Villarreal. And remind you as well that we will send you a certificate and surveys. We will appreciate if you could fill out this service. That will help us improve these webinars in the future. And again, remind you about the ICFSR meeting, which is taking place in April 20 till April 22 in Boston. There is a late call for abstracts till March 17. So thank you very much, everybody. It was a wonderful evening.
Thank you very much for the presentation. Bye-bye.
Thank you. Bye.
Thank you. Bye.
Thank you, Mikel. Great presentation. Thank you all for participating. Thank you, Carmen, for great moderation. Gracias.
Thank you. Bye.
Okay.